All right, welcome back from the break. I'm Mark Humine, and we're going to get started with late-breaking developments. I have an esteemed panelist, members here, Jonathan Chang, Andrew Rumasa, and Scott. So without further ado, I'll have Jeremiah speak.
Good afternoon. It is my pleasure to review with you the year one data for the ELEVATUM trial. I think you're going to find this to be a unique and interesting trial that's going to give us data that we can use in the clinic every day. I'd like to thank my co-investigators, and these are our disclosures. So we all see in clinic that certain populations present with more severe disease, worse visual acuity. And unfortunately, often these groups are underrepresented in clinical trials. So ELEVATUM's goal was to look at this population of patients and evaluate Faricimab efficacy and safety in this group. 124 patients were enrolled across 40 sites in the United States. Patients had to self-identify as being Black or African American, Hispanic Latino, or Native American or Pacific Islander. Patients had to have a hemoglobin A1C of 10%. Up to 20% of patients could have an A1C of up to 12%. Patients had to have center-involved DME, and the visual acuity requirement was similar to what you saw in Yosemite and Rhine. So let's just look at some of the comparisons with Yosemite and Rhine. So in ELEVATUM, one key difference is every patient was treatment naive. You can see that the hemoglobin A1C was up to 12% in 20% of patients, and the goal was to get about 45% Hispanic Americans, 45% African Americans, and 10% Native Americans and Pacific Islanders. You can see the numbers in Yosemite and Rhine. There was about 16% Hispanics and 6.6% African Americans in the total cohort. So the structure of the protocol was designed to match the fixed dosing interval arm in Yosemite and Rhine. So patients got an injection on day one, then 5 monthly injections. Then they went to every other month out to a year. Some key things that we noticed and the baseline characteristics. If you take a look at the central subfield thickness, Hispanic Americans had thicker retinas. 491 microns was the average thickness in their retinas, compared to 467 microns in the African American cohort. The best corrected visual acuity was slightly lower in the Hispanic Americans, 59 letters compared to 62 ETDRS letters. Now, if we look at Yosemite and Rhine, we saw some similar numbers, the central subfield thickness being 490 microns in the Hispanic Americans and 482 in the African Americans, and the visual acuity 60 and 63 letters respectively. Other point to make in terms of the disease severity, Hispanic Americans presented with more severe disease. So 40% of them had moderately severe to severe non-proliferative diabetic retinopathy, and 16% had PDR, compared to in the African American group, 70% of the patients had mild to moderate NPDR, and that's going to be important when we look at the step improvements, which I'm going to share with you later. Now, in Yosemite and Rhine, it was similar. You see there's a 44% who had moderately severe to severe NPDR in the Hispanic American group, and about 13% that had PDR, compared to 1% with PDR in the African American group, and 60% that were in the mild group. Okay, so what do we find? Overall, you can see the overall population did great. Visual acuity improved early and consistently continued throughout the study out to year one, gaining 12.3 letters compared to 11.2 in Yosemite and Rhine. The African American cohort gained 11.3 letters, and the Hispanic cohort knocked it out of the park with 14 letters gained in 1 year of treatment. If we look at the anatomic results, similar findings. You see that the improvement occurs early. Overall, 206 microns of improvement in retinal thickness. The African American cohort had 193 microns of improvement, and the Hispanic American cohort improved to 230 microns of improvement on their retinal thickness. So now let's look at the disease severity scale. 40% of Hispanic Americans had a two-step improvement by month 5. That was astounding. You can see that pretty much persisted throughout the study. In the African American group, we went from 11% at month 5 to 17% with 2 steps of improvement at year 1. But remember that 70% of that group was in the mild to moderate category, so they really didn't have as much room to improve over the course of the study. Next issue, safety. That was one thing that was thought to be a concern in this population. Nice thing to find is that it was very similar to the overall safety in Yosemite and Rhine. In terms of inflammation, there were 3 cases of iritis. They were deemed by the investigators as being mild. They were treated with topical steroids, and they stayed in the study and continued to get injections. There was 1 case of endophthalmitis. There were no cases of vasculitis, and there were no APTC events. So take-home message would be, yes, you can. You can get robust vision gains and improve central subfield thickness, even in these more severe, difficult-to-treat cases, if you treat them consistently on label with those monthly loading doses in the beginning. Hispanic Latino patients had worse disease at baseline, worse vision, but they had the greatest improvement in best-corrected visual acuity, central subfield thickness, and their diabetic retinopathy disease severity. And overall, faricimab was well tolerated. No new safety signals were seen. This study is actually going to be a treasure of data that we're going to be seeing coming out over the next couple of years. Looking at systemic disease and its interplay, there were frequent aqueous humor taps throughout the study, looking at VEGF levels, Ang2 levels throughout the course of the study, looking at social determinants of health and how that may impact the clinical outcomes. And then with all these OCTs, we're going to be using AI to analyze for biomarkers that may predict who are the patients that are going to do the best, maybe who need that Ang2 inhibition in addition. And there's a long-term extension study. So now in year 2, patients can go along a personalized treatment interval, and they can be extended out to 24 weeks if they meet the criteria. So this was the first industry-sponsored trial for underrepresented patients in retina. The study recruited rapidly, which was really surprising. It kind of broke the conventional wisdom. And not only that, the completion rate of 87% was better than most people expected. This increased the biomarker diversity data that Genentech has in terms of aqueous humor samples by 169% and genotyping by 49%. And their other goal was to improve speakers and the diversity of speakers and investigators who represent the patient population. So I want to thank all the investigators and all the patients who participated in this trial. Thank you.
Thank you, Jeremiah. Okay, our next speaker will be Diana Doe.
Thank you very much. On behalf of my co-investigators, it's my pleasure to share key results from the PHOTON extension study. My disclosures are noted here. Recall that the PHOTON study met its primary endpoint in that Aflibercept 8 milligrams dosed either every 12 weeks or every 16 weeks was non-inferior to Aflibercept 2 milligrams dosed every 8 weeks. After completion of the PHOTON study, patients had the option of participating in the extension study. In the extension study, eyes that were initially randomized to Aflibercept 2 milligrams were then switched to Aflibercept 8 milligrams dosed every 12 weeks. Eyes that were initially dosed with Aflibercept 8 milligrams remained on this according to their last interval. In the extension study, eyes could be extended or shortened in 2-week increments based on pre-specified criteria. The minimum shortening was 8 weeks, and the maximum extension was 24 weeks. If we look across, we can see that 265 patients participated in this extension study, and 79% completed the week 156 visit. In addition, the baseline characteristics were well balanced between the PHOTON participants and those who participated in the extension study. Now let's take a look at visual acuity. All patients had robust, rapid, and sustained improvements in their visual acuity through 2 years of the PHOTON study. And these visual acuity benefits were maintained during the extension phase, with a mean gain of 7.7 letters. If we take a closer look at the 2 different groups, the 2 milligrams of Aflibercept and the 8 milligram Aflibercept group, their visual acuity gains were both comparable across the 2 years of the PHOTON study. And when the 2 milligram group switched over to 8 milligrams, these benefits were maintained with average gains of 7.2 to 7.9 letters, with fewer injections over time. What about retinal anatomy? Patients treated with 8 milligrams of Aflibercept had rapid reductions that were robust and sustained through 2 years of treatment. When we transitioned to the extension phase, these benefits were maintained with a mean reduction of minus 187 microns at week 156. If we take a closer look at the 2 milligram Aflibercept treatment group, one could notice a sawtooth pattern in retinal fluctuation during the first 2 years of the PHOTON study. Remember, in the extension study, these eyes were transitioned to Aflibercept 8 milligrams. And after a single injection, there was a rapid 54 micron reduction in retinal thickness. And this corresponded to the lowest central retinal subfield measurement in these subjects in the study. As the extension phase went on, these patients received 8 milligrams of Aflibercept. We can see that these anatomic benefits were maintained with fewer visits and fewer injections over time. Finally, we see that the majority of Aflibercept-treated eyes had extending dosing intervals through 3 years. In fact, 45% of subjects had completed a dosing interval of 20 weeks or greater. And furthermore, those eyes that were transitioned from 2 milligrams to 8 milligrams of Aflibercept, 83% of these eyes could have a dosing interval of 12 weeks or greater. What about ocular safety? Well, there were no surprises, and Aflibercept 8 milligrams had comparable safety as Aflibercept 2 milligrams, with very low rates of intraocular inflammation and no cases of occlusive retinal vasculitis. Furthermore, there were no systemic safety signals. In conclusion, the PHOTON extension study has showed very key findings. First, Aflibercept 8 milligrams results in improved visual acuity and reductions in retinal thickness that were sustained and maintained through the extension study. In fact, 45% of patients had intervals of 20 weeks or greater. When we switched 2 milligram Aflibercept eyes to 8 milligram Aflibercept, these eyes continued to do well with fewer injections, fewer treatments, and sustained improvements in visual acuity. 83% of these eyes could be dosed 12 weeks or greater. And finally, the safety of Aflibercept 8 milligrams is comparable to that of Aflibercept 2 milligrams. Thank you for allowing me to share this information.
Thank you, Diana. Our next speaker will be Joe. Joe? How goes it?
Hey, how's it going?
Good.
Hey, thank you, Mark. Thanks for the opportunity to present the safety and efficacy data of RZ402 from Resolute Bio. This is a novel orally administered plasma kallikrein inhibitor, and this is a phase 2A study in patients with diabetic macular edema. Disclosures, mostly research support. Plasma kallikrein, it's part of a family of serine proteases, as you all know, and the plasma kallikrein itself is somewhat different from tissue kallikreins, but it's a protease that activates bradykinin and then creates this kinin molecule that has tremendous effects on vascular permeability, vasodilation, and largely other vascular effects. In diabetes, we think that this may be a secondary pathway in terms of development of macular edema, and that inhibiting this pathway may have some beneficial effects. All of these effects are independent of VEGF, so it's a different pathway altogether. This is an orally administered medication, so it has the advantage of potentially augmenting the effects of anti-VEGF that we're very familiar with, and has the advantage of treating both eyes simultaneously. The study design, there were 100 patients initially randomized 1 to 1 to 1 to 1 in one of 3 ascending doses, either 50 milligrams, 200 milligrams, or 400 milligrams of orally administered RZ402, and then a control group of 25 participants. The patients could have had previous anti-VEGF treatment up to 3 injections, but the last injection had to be 8 weeks or longer before they were randomized. And CSTs had to be 320 in males and 305 in females, and the visual acuity was 20/32 or worse, or 78 letters. The study was 3 months, and then the patients were followed for an additional month after their last dosing. The primary endpoints were safety, looking at AEs and SAEs, ocular exams, etc. These drugs have some effect on blood pressure and liver function, so that was the primary goal, and to see whether there was any efficacy signal in terms of central subfield thickness. Secondary endpoints were vision and changes in DRSS, but in all honesty, we weren't really expecting to see much in such a short study. The baseline demographics were pretty evenly matched in terms of age and gender. The diabetic retinopathy scores were generally DRSS 43 or better. There, about a quarter of the patients had slightly worse retinopathy, and the average CST was a little over 400. The average BCVA was around 2040. The primary endpoint of safety analysis was pretty favorable. The A's were generally mild. In terms of ocular effects, there were basically none. Hypertension was extremely mild. The gastrointestinal effects were also mild and well tolerated. No changes in hepatic enzymes or liver function that could be detected. And then heart functions and vital signs were all basically normal with the drug. In terms of study eye CST, there was a modest decrease in all the dosing regimens in CST, ranging between 25 and 47 microns, so not anti-VEGF level, but modest effect on CST in all the treatment cohorts. In terms of eyes that had significant thickening, more than 400 microns, all the drug cohorts showed some modest reduction in CST compared to the placebo group, where there was an increase in the CST. Here's an example from one of the patients where there was a moderate reduction in CST of a little over 100 microns on oral drug only. If you look at the fellow eyes, so some of these patients, 12 of them in the trial had evaluatable fellow eyes. There was a similar effect, although not quite as robust, in the 50 and 200 milligram dosing. In terms of BCVA, there was really no discernible difference in the study. The control group had an unexpected increase in CST with increase in visual acuity without treatment. If you take out that very early 2-week bump in vision in that group, there was maybe some modest effect, but modest at best, probably not statistically significant. So in conclusion, this is the first plasma kallikrein inhibitor and oral therapy in any class to demonstrate central subfield improvements in patients with DME. This was observed at all the dose levels. The vision was not expected to improve and really did not in this very short study, but the results were significant enough to warrant a phase 2b/3 study that is coming. The drug seems to be well tolerated and safe systemically. Thanks for the opportunity to talk. Okay.
All right. So we'll discuss the first 3 papers now, so I'll ask my panelists to ask questions. Does anyone have questions of the first 3 speakers? Scott, maybe you can kick us off.
Yeah, as you know, I have lots. So we'll start with the first paper. You talked about, so recruitment, as we all know, is challenging in underrepresented patients for clinical research. And the question is there any evidence that treatment would be different in the underrepresented patients versus the non-underrepresented patients for DR, DME?
Sure. There's one paper that's really interesting that showed that African Americans had a poor response to bevacizumab, to a single injection, and they looked at by race. And so there's another paper that looks at polymorphisms of the VEGF receptor, and certain polymorphisms may respond better than others. So, I mean, I think that there is some reason to think that perhaps, based on race and which gets into diet, which gets into culture, which gets into genetics, that one molecule might work better in one group of patients than another.
Chairman, may I ask a question?
Yes.
So for those of us who do lots of clinical trials, this is an obvious deficiency in like the clinical trial epistemology, so to speak. And so 2 questions. One is, what can we do better to recruit and enroll and maintain patients in studies like this? And are we just artificially dividing according to race and ethnicity? I mean, there's a lot of complexity in the African American population and the Latinx population. Like, these buckets are kind of artificial themselves.
Yeah.
How granular should we get?
Yeah, it's really interesting. You know, I've been asked this question before. One thing that you can say is if you just look at the data and how people present, certain populations just present differently. Like you could see in both Yosemite and Rhine, 490 microns being the average thickness in the Hispanic group, and it was repeated again. And so, really what we're trying to get to is how can we best treat our patients? So, realizing that there's all those other factors that go into what we consider race, and outcomes. It's not just genetics, it's all these other factors. There do seem to be differences, so I think it's worth learning about it. Perhaps, some people have more inflammatory component to their diabetic macular edema, and maybe that's why Ang2 seems to help. That needs to be proven, but maybe that is why. And one thing just anecdotally that I noticed that was like my wow effect was looking at the thick retinas with exudates and just seeing those exudates melt away in that first year, and people that I wasn't expecting to see that in people who were in the trial. So I do think there is some usefulness in studying these groups. What can you do? I think making your patients feel comfortable in your environment, from the top down, clinic and research. Offering fellow eye treatment. 70% of the patients in this study actually had fellow eye treatment. Offering stipends, helping with childcare for patients who come in after work, transportation, having materials in your clinic that have their native language in it, making that available, and just your approach to it, how you talk to the patients. Don't just assume, oh, they're not going to want to be in research. They've got enough things going on in their life. You got to ask them.
Yep. Thank you, Jeremiah.
Thank you.
I just had a follow-up question to that. We do put patients in buckets of race and ethnicity, but the social determinants of health are probably contributing quite a bit to these outcomes. And you mentioned a little bit about looking into that. Could you talk a little bit about which social determinants of health you're looking into?
Yeah, and keep that quiet. Otherwise, the other is short because the other speakers are going to feel totally disregarded. I have some questions for them.
Very quickly, things like zip code, education, socioeconomic status, those things were all gathered through this study.
Great, thank you. So I have a question for Joel. Joel, I believe a previous PK was studied by Calvista or something like that. Am I remembering that correctly?
Yes.
How is this different than that previous study?
If I recall correctly, that was an intravitreal drug. This is an oral drug. There is some thought that the plasma kallikrein works at the level of the endothelial cells, and that the intravitreal dosing may not penetrate so well, but a systemic dosing might. And so the thought was that this may have shown an effect on CST because it's actually working at the site where kallikrein and kinins have their greatest effect on the inside of the blood vessel.
Okay, great. Any short questions?
I have a
for
follow-up
Joel?
question for that too, and it's exciting to have an oral agent that's showing a signal potentially with diabetic macular edema and some safety. As far as looking forward, are there plans to look at this as a combination therapy, or what are the strategies for next steps?
Yeah, I think that the phase 3 probably will be single dosing, but yes, I think that combination makes the most sense. And there's some thought that perhaps some of the patients with DAB who are somewhat resistant to anti-VEGF or anti-VEGF, anti-Ang2 alone may have this other mechanism at play, and it may be adjunctive treatment for them as well. So lots of studies to be done.
Question for, you want to ask Diana a question?
Yeah,
or you want to
so
ask
for
Joel a
Diana, since she doesn't get left out, we now have two, what I call second-generation anti-VEGFs, which have shown similar clinical efficacy and greater durability compared to the other anti-VEGFs for treatment of DME. So when selecting a drug for a patient sitting in front of you, and you're going to use one of those two the second-generation drugs, how do you decide which drug to use? Dan also said the network's not going to do a comparative trial. In your opinion, does a comparative trial need to be done, or how do we adjudicate that?
It is very interesting that we do have these new therapeutic options for our patients, and both are very effective. They do show extended durability. I think a lot of patients, let's say if they were already on Aflibercept 2 milligrams, it is maybe natural to think about using Aflibercept 8 milligrams in those patients. And we do have evidence now that when you switch over to the higher dose of Aflibercept 8 milligrams, you can have additional anatomic benefits shown in this PHOTON extension study. So I think I choose based on what my patients currently are on. And certainly we can also start any of these agents on treatment-naive patients because they also do extremely well on these more extended durability agents.
Okay, let's thank the first three speakers. And if we can have them go off stage, we'll have Alex come up next.
All right. Thank you to the Planning Committee for accepting this presentation as a late breaker. On behalf of the entire team, I'm happy to present the results from SAGA, a 2-year randomized double-masked placebo-controlled study looking at Gildeuretinol in geographic atrophy. My disclosures. Gildeuretinol is an investigational oral agent designed to replace vitamin A in the visual cycle. Structurally, it's almost identical to vitamin A with the exception of 3 hydrogen atoms in the C20 position that are replaced with deuterium. This drug is metabolized exactly like vitamin A systemically and works like vitamin A in the visual cycle, with the exception of the fact that this chemical modification slows dimerization. Vitamin A dimerization has been implicated in the formation of lipofuscin and RPE and photoreceptor degeneration. Therefore, it is our hypothesis that by slowing vitamin A dimerization with Gildeuretinol, we can reduce disease progression, slow lesion growth rate in geographic atrophy related to AMD. So a number of disease states, dry AMD, wet AMD, and Stargardt, have this basic common pathophysiology, and that's the accumulation of vitamin A dimers that occur early in the injury cascade. In dry AMD and geographic atrophy, dimers have been implicated in complement activation and dysregulation. SAGA is a 2-year clinical study evaluating the safety and efficacy of Gildeuretinol in geographic atrophy secondary to AMD. In this study, patients were randomized 2-to-1 to treatment versus placebo. Follow-up visits were conducted every 6 months with a primary efficacy endpoint planned at month 24. The primary efficacy endpoint was the rate of lesion growth of geographic atrophy as measured by fundus autofluorescence and confirmed by OCT from baseline to month 24. Key secondary efficacy endpoints were low luminance visual acuity and best corrected visual acuity. Patients were included in this study if they were 60 years or older, had at least one well-demarcated geographic atrophy lesion, eyes both with and without subfoveal involvement were included. Active or inactive choroidal neovascularization in the study eye was an exclusion criteria. However, choroidal neovascularization in the contralateral eye was not exclusionary. And patients who had both eyes that met inclusion criteria could be randomized for analysis. In this slide and further slides, you're going to see tables like this, and here we have Gildeuretinol in one column and placebo. You will see the numbers of patients and percentages in parentheses. We're looking at subject disposition between the two groups, and overall what I'd like to highlight is that 70% of patients completed the study in both groups. The most common cause for a discontinuation was withdrawal by subject, and this was relatively similar between the two groups. In this slide, we see demographics and baseline characteristics. The mean age of patients in both study arms was 78. They were predominantly female and Caucasian. As with other studies in this space, most patients had subfoveal lesions, and most lesions were multifocal GA lesions. The primary efficacy endpoint was the rate of lesion growth from baseline to 24 months, and this did not reach statistical significance. The p-value was 0.075. However, we do see a separation of effect starting at month 6 and reaching a 13.4% growth rate reduction in the gilduretinol group as compared to placebo at final follow-up. Pharmacokinetic studies have demonstrated that it takes several months with oral gilduretinol supplementation to achieve an 80% turnover of deuterated vitamin A in the body. Therefore, a pre-specified sensitivity analysis was planned looking at the rate of lesion growth from 6 to 24 months, and this did reach statistical significance, demonstrating a 15.3% growth rate reduction at month 24 in the gilduretinol group as compared to placebo. Low luminance was a first secondary endpoint for this trial and was particularly interesting because in preclinical studies, dimerization, the accumulation of dimers, have been demonstrated to decrease dark adaptation. In this trial, patients treated with gilduretinol suffered less loss of letters and on visual acuity testing at final follow-up than patients in the placebo group, and this was statistically significant. Of note, this is the first oral therapy to demonstrate improvement or stabilization on low luminance visual acuity. No statistically significant benefit on best-corrected visual acuity was noted over the course of the study, although at final follow-up, patients treated with gilduretinol preserved 3.3 or lost 3.3 less letters than patients in the placebo group. In this table, we're looking at the safety profile in the two groups. Again, you see gilduretinol and placebo, and we're looking at treatment-emergent adverse events. This is an oral medication, so systemic effects are top of mind. Looking at the two groups, we see that most treatment-emergent adverse events were mild or moderate in nature. Importantly, no deaths were attributed due to study drug. Interestingly, there was a lower rate of choroidal neovascularization-related adverse events in at-risk patients in the gilduretinol study group. There were no reports of delayed dark adaptation or chromatopsia, vasculitis, IOI, endophthalmitis, symptoms of hyper or hypovitaminosis A. So in summary, decreasing vitamin A dimerization is a potential mechanism of action to treat geographic atrophy. Compared to placebo, we see that there is a trend towards slower GA lesion growth from baseline to month 24, a statistically significant slower GA lesion growth rate from 6 to 24 months, and statistically significant functional vision benefit on low luminance visual acuity. And this is the first investigational oral agent to demonstrate this. Gilduretinol was well tolerated and exhibited a favorable safety profile consistent with other studies in the gilduretinol study Stargardt program. We'd like to thank the clinical trial participants, families, caregivers, the SAGA clinical trial staff, and the NIH for supporting this study.
Thank you. Dilsher. Okay, good.
Great. Well, good afternoon, everybody. It's my pleasure to present to you the efficacy and safety of continuous Pegcetacoplan treatment for subfoveal geographic atrophy in age-related macular degeneration. I'd like to thank the organizing committee for the opportunity, as well as the investigators at Oaks, Derby, and GALE. These are my financial disclosures. Of note, I'm a consultant and investigator for Apellis. Geographic atrophy lesion location affects growth rate. You can see in the graph on the right here, sham growth rate by lesion location. And both non-subfoveal and subfoveal lesions grow, but in the gray there you see the non-subfoveal lesions grow at a more rapid rate. The Oaks and Derby population was quite heterogeneous. We saw about 1/3 or 35% of patients were non-subfoveal, and 2/3, the majority, were subfoveal lesions. We now have had FDA approval of this drug for 18 months. And the question often comes up, much like in the spirited debate earlier, who are the most appropriate patients for treatment? I'm going to submit to you today and hope to demonstrate based on data the importance of treating subfoveal geographic atrophy. And how do we define subfoveal? Well, this is defined as a lesion that involves a foveal center point on fundus autofluorescence and OCT. Here are two examples. There's a multifocal lesion at the top. This patient's a relatively large lesion at 7.4 millimeters squared. The visual acuity is better than you might expect at 20/80. At the bottom there, you see a unifocal lesion with visual acuity of 20/60, also better than you might expect. If we look at the population, 765 patients, and look at the baseline visual acuity, it turns out that 82% of eyes with subfoveal GA had vision better than 2200 or legal blindness. And almost a quarter, or 22%, had vision better than 2050. The mean baseline visual acuity was 2100. GALE is the largest open label extension and longest clinical program in geographic atrophy. Patients were eligible to roll into GALE if they decided to at the 24-month mark. Patients on Pegcetacoplan continued on the same regimen. Sham patients crossed over to active treatment at the same interval that they were on before. The efficacy analysis changes. You have an actual sham from 0 to 24 months, but months 24 to 36 is a projected sham. The retention rate was excellent at the first year of GALE at 92%. Here we see the results from the non-subfoveal GA, which showed 32% reduction at 36 months in the monthly group, 26% reduction in the every other month group. Increases were seen year over year. In the final year, the third year, we saw 42% reduction in the monthly group and 28% reduction in the every other month group. Focusing now on subfoveal patients, Pegcetacoplan showed increasing efficacy over time in the subfoveal population with as few as 6 injections per year. Overall, 21% and 19% in the monthly and every other month group at 36 months, with the greatest reductions in the third year, 31% and 25% in monthly and every other month. We can also compare the study eyes to the subfoveal fellow eyes. And so you see on the left here the Pegcetacoplan monthly patients compared to the fellow eyes. The numbers are very similar to what you see for sham and projected sham. Again, offering validity to the projected sham usage in this population. On the right side, you see every other month. Again, you can see every other month at 18% reduction overall and monthly at 26% reduction. Again, very similar to the sham and projected sham. Ultimately, Pegcetacoplan treatment preserves clinically meaningful retinal tissue in subfoveal GA, increasing over time. We see 1.1 and 0.98 millimeters squared preserved at 36 months. Let's switch to function. So microperimetry bridges retinal structure to visual function. We've seen from Chroma and Spectri that microperimetry showed the highest correlation with geographic atrophy area compared to other visual function endpoints. Of course, microperimetry measures patient-reported perception of light, stimuli, or variable intensity, and the mean examination time in OAKS was 8.8 minutes. In this first analysis, the number of new scotomatous points were plotted, and visual function benefit was demonstrated for the first time in the subfoveal GA population. Here you can see a consistent signal at 12, 24, and 36 months, which is significant in the monthly group at 24 and 36 months, with less new scotomatous points on microperimetry. If we look at the central 4 loci, we see that Pegcetacoplan reduces risk of progression to absolute scotoma in the central 4 loci, 32% risk reduction in the monthly group, 29% risk reduction in the every other month group. Similarly, we can look at the 16 central loci, and again we see risk reduction 43% in the monthly group, 54% in the every other month group. This is a poignant case. This patient is a Derby GALE patient, a 68-year-old female with bilateral subfoveal GA. You can see that the lesions are very similar at baseline, 12 millimeters squared approximately in both eyes. The visual acuity is 45 and 48 letters, so very similar. Let's see how the patient does. 36 months later on treatment with Pegcetacoplan, this patient has a change of 3.52 millimeters squared, or a growth of 29%. The visual acuity is relatively stable, a 2-letter loss. The untreated fellow eye has a change of 10.45 millimeters squared, or 88% gain in atrophy, with a loss of 23 letters, 25 letters. So in asking the question who might be appropriate for Pegcetacoplan, I would submit to you that this is certainly a patient that would be. In terms of safety, the safety profile in the first 12 months of GALE was consistent with OAKS and Derby, including events of interest such as infectious endophthalmitis, ischemic optic neuropathy, IOI, exudative AMD. There were no study events of occlusive or non-occlusive retinitis or vasculitis. We have seen post-marketing safety, 1 out of 4,000 per first injection rate of retinal vasculitis, which appears to be a first injection phenomena. In conclusion, Pegcetacoplan is the only FDA-approved therapy to demonstrate efficacy in subfoveal GA. We see increasing effects over time through 36 months with as few as 6 injections per year. And finally, when it comes to visual function, we see a benefit demonstrated in subfoveal GA utilizing microperimetry with Pegcetacoplan. Thank you all for your attention.
All right, we're going to go into discussion and discuss the next 2 papers. So, panelists, do you have questions for our speakers?
I had a question for Alex. That was a great study. The question I had was, were your patients continuing the AREDS vitamins during the course of the study? And also, was there anything built into the protocol to monitor their compliance with taking this medication?
That's a good question about the AREDS vitamin. I actually don't have that answer on me right now. With regard, I believe they were, but I would have to get back to you for sure. With regards to compliance, patients were asked to bring back their bottles, and they were verified how many pills that had been taken or not taken.
Thank you.
I had a question for Dr. Dhoot. So one question that comes up a lot for patients when they're presented with the option of getting treatment for geographic atrophy is, how much more time does the treatment kind of buy them in terms of good vision and preservation? Do we have information? We see that the growth rates are slowed, but in some cases that doesn't always lead to improvement in some of the functional testing. So do we have a sense of how much time extra, treatment actually helps our patients?
Yeah, that's a difficult question. Really, it depends on the specific patient, right? And so, we have different growth rates for different patients, and we know that non-subfoveal lesions are growing faster. And certainly, the hope is that with AI and imaging and past imaging, that we'll have some sense of that. It would be very helpful for patients to know. It would also play into knowing how much they're benefiting. So, but the amount of time yet is still kind of something that's we don't yet have.
Scott? Yeah.
So, Frox, the 70% dropout rate was very high, and that's worrisome because you don't know what the 30%, whether they were getting better or worse, and so you don't know whether if they were included, whether the data would have been the same. Also, the TEAEs were greater in the placebo group than the study group, and the discontinuation was greater in the placebo group than the study group. Can you comment on that? Why did the placebo group drop out? And why they have more adverse events?
Yeah, I just don't think that the dropout had anything to do with the adverse events. I think what it shows us is that there's really, in this patient population, the compliance rate and the dropout rate can be hard to predict. This was different from a lot of the other studies where patients are seen monthly for intravitreal injections and therefore for 6-month follow-ups. And this was also during the pandemic, so there could be multifactorial reasons for compliance. But as far as, you're right, there were more TAEs in the placebo group, and I think that what this shows me is that this is noise, that there really wasn't a drug-related increase in TAEs.
And can I ask one more question?
Sure.
So for Dilsher, so we found out that most people in this room don't want to inject for GA. So for the few people in the room, including me, that do still inject, if you have a lesion that's a small lesion that's well away from the subfovea and the vision's really good, you showed 42% compared to 28% for every other month. Do you really think it's beneficial to inject those eyes or wait till they start becoming center threatening?
I think if a lesion is far enough away, I may be comfortable watching that lesion, But if I'm seeing growth, year-over-year growth of a lesion, documented growth based on imaging, then I think it is reasonable to inject that patient, and I think they would derive benefit.
Yeah, I had a question. Oh, you had a question? Go ahead.
Yeah, I had a question for Dr. Dhoot as well. So we know that GA is a very long-term condition. It moves very slowly, so it's great that we're getting these longer-term data. However, it's really important to have a randomized control group to sham just to control for some confounding. They used a projected sham group. Could you comment on that, how that projected sham was calculated, whether things like the proximity to the fovea of the lesions at the point that it turned into projection sham were taken into consideration? Thanks.
Yeah, so the projected sham is based on rationale from study by folks like Janet Sinnes and others, paper in Ophthalmology 2007, looking at patients who had 4 or greater years of follow-up. And what they found was that 2 years of GA growth is very predictive of the subsequent 2 years of GA growth. And so the projected sham in that fashion was a linear design. So we saw in the projected sham is 2 millimeters squared per year. And then when we looked at the fellow eyes, we also saw that it grows right around 2 millimeters squared per year in the fellow eye. So I think that the projected sham is a validated method, and we can use it in up to 48 months out based on that validation. Thanks.
Great. All right, I'd like to thank the speakers, and if you would please. Okay, our last speaker is Eric.
Thank you, and on behalf of my co-investigators, I'm pleased to present pivotal trial outcomes of AI-based home OCT. Here are my disclosures relevant to this talk. I'm a consultant and received grant support from both Notal Vision and Carl Zeiss Meditech. So it's my great pleasure to be able to present for the first time the pivotal trial design and results that have led to the FDA approval of the first ever home OCT device. This slide is a conceptual overview of the study design and key endpoints. There was a two-part study design. The first was the qualitative visualization study, which assessed, number one, whether neovascular AMD patients could adequately self-image at home, and number two, whether the visualization of key biomarkers was qualitatively the same between in-office and home OCT as gauged by expert reading center graders. The second of the pivotal trials was the quantitative AI study, which assessed whether the estimation of key neovascular AMD biomarkers was both repeatable and quantitatively similar between expert graders and artificial intelligence. I wanted to highlight some important definitions that will be relevant to our discussion moving forward. The first of these is hyporeflective spaces, or HRS. These are the low reflectance abnormal voids that we typically see in cross-sectional OCT imaging. We see an example of that at the image at the upper right. IRO and SRO are hyporeflective spaces that are present in the intra and subretinal spaces respectively, and we see those delineated in green and blue at the image at the lower right. TRO, or total hyporeflective spaces, are the sum of the IRO and SRO within an OCT volume. And finally, volume units are the unit of volume measurement of TRO with one volume unit equivalent to 1 nanoliter of fluid. In the case of HRS, it does represent retinal fluid. We'll move on now to the first of our pivotal trials, the visualization study. This was a prospective longitudinal study enrolling patients meeting the inclusion and exclusion criteria listed here at the bottom of the slide. Patients were identified 1 week prior to a planned office visit. Enrolled patients subsequently had a home OCT device drop shipped to their home by the monitoring center. They completed self-setup and calibration with the assistance of a video tutorial on the device and activated 5 weeks of daily home OCT imaging. During this time, there were 2 mandatory study visits at week 1 and week 5, during which visual acuity testing, serous OCT macular scanning, and adverse event recording was performed. Additionally, there was a reading center triggered interim visits if changes were noted on daily home OCT images by the reading center graders. There were 2 key outcomes that we assessed in this study. The first was the visualization agreement for TRO between home OCT and in-office OCT, and we assessed this by looking at the positive and negative % agreements. We additionally looked at the adequacy of self-imaging at home, looking at the metrics that we have listed here on the right of the slide. So here are the characteristics of the 180 patients that were enrolled in the visualization study. It was a typical neovascular AMD patient population from a demographic standpoint, with about 40% of patients having baseline TRO present on their initial imaging. If we move on to our results, we see that for the visualization agreement, the home OCT device did meet the pre-specified endpoint with an 86% positive % agreement and an 87% negative % agreement. 96.1% of patients were able to activate, calibrate, and initiate self-imaging with an adherence rate of 5.9 scans per week and a median time per scan of 48 seconds, which demonstrates excellent device usability. Move on now to the second of our pivotal trials, the AI study. This was a cross-sectional, single-visit prospective study that was performed in the office setting. The inclusion and exclusion criteria were similar to the visualization study, and again are listed here at the bottom of the slide. In this study, patients self-imaged multiple times on 2 separate home OCT devices and were imaged a single time with a standard in-office serous OCT device. all home OCT-acquired B scans were subsequently processed for segmentation and volume estimation by the home OCT-associated AI algorithm, and to allow for comparisons of repeatability and agreement. 3 independent reading center graders performed a similar analysis and determined the same metrics for 10% of the B scans on a single home OCT volume, as well as the in-office OCT volume. There were also 2 key outcomes in the AI study. The first was repeatability in terms of quantitative volume estimation. We assessed this by looking at the coefficient of variation, and for this outcome, we looked at 2 different device grader combinations: repeated home OCT with AI grading as compared to in-office OCT with multiple reading center graders. The second key outcome was agreement in terms of segmentation similarity, and we assessed this by looking at the DICE similarity score. We took a comparative approach for this outcome and looked at all all grader AI pair combinations, and this allowed us to perform a comparison agreement between AI and a single grader with the agreement between 2 independent human graders. Here are the baseline characteristics for the AI study. This was a 336-patient study, and again, a fairly typical neovascular AMD patient population. Of note, there was a much higher rate of baseline TRO present in this group, about 90% on initial imaging. If we look at our results for repeatability, we see that the coefficient of variation for the home OCT with AI grading group was 11.1%, and that is compared to 16.4% for in-office OCT with reading center graders. And this was for patients with at least 10 volume units of TRO on their OCT volume scan, which we felt was the lower limit of clinically meaningful amounts of TRO. Both device grader combinations demonstrated a good precision with a lower amount of variability in the home OCT with AI grading group, and we certainly felt this was at a level that should allow for identification of clinically meaningful trends in TRO change over time with daily imaging. We also saw excellent results for agreement of segmentation with AI grader DICE scores on par with those between 2 human graders, as we see graphically here. So in summary, patients demonstrated a high success rate and adherence to daily home OCT imaging. The comparison of home OCT with in-office OCT for qualitative visualization of TRO did meet the pre-specified endpoint, and comparisons of AI-based estimations of hyperreflective spaces with that of human graders showed good precision and quantitative agreement. And the overall system performance did meet a high bar of efficacy and safety, and was thus able to achieve de novo marketing authorization by the FDA. Thank you for your attention.
Great. You can just stay right there. Okay. Questions for the speaker? Go ahead.
So, as you know, there's a lot of enthusiasm for home OCT. It was FDA approved. The network's doing a study. My question to you is, what do you think are the barriers to home OCT? Usability, lack of efficacy, payments, et cetera?
Yeah, well, you hit on a lot of them. I mean, certainly I think there's a certain degree of inertia that's going to have to be overcome. I think we're all very comfortable with using in-office OCT, but I think those of us in the audience or in the panel here who have had a chance to review some of the data that comes out of these devices, I think you're going to notice a big difference in sort of the granularity of the details we get on patients' sort of disease activity and response to therapy. And so, but I think there are several things I think we worry about in terms of barriers. One is financial, right? So what are the payments going to look like, both from the provider perspective? Will it be covered by Medicare, right? There's a separate code that is part of this submission that allows for billing every 30 days for this device to be utilized. So I think that's one aspect. I think other thing, there's concerns about sort of workflow or workload, right? If you've had the opportunity to log into the home OCT portal, you'll know that it's actually fairly seamless, and there's lots of data there, right? You can scroll through every day's OCT volume if you wanted to. You can look at these en-face projections of where the intra and subretinal hyperreflective spaces are, but really all you have to do is look at the trajectory, right? And that's really where all the data is, right? And I think that is another thing. It's going to be an educational perspective. How do we get providers comfortable with looking at that? It's going to be different than what we're used to with in-office OCT. I don't think there's going to be a big barrier, in terms of having the patients get set up with. I mean, I think Notile has experience with that, with the 4C home device, and so I think there's a good infrastructure there. But obviously, there's going to be more the prescribers kind of inertia.
Yeah, how often does an elderly patient at home with 20 200 vision be able to use this device? I mean, I didn't get a good feel from your data.
Yeah.
Because garbage in, garbage out, right?
Exactly.
I mean, once you get good data.
It's a great question, yes. So I did gloss over it a little bit, but the visual acuity requirement to be in the study was 2320 or greater. If you look at, so two factors. One is, what was the frequency which people could calibrate, right? And so between the two studies, it was between 4 to 8% of people failed calibration. So it's still a relatively low rate. And then you look at the next step would be, what's the rate of poor image quality, right? So ungradable images, which is, again, your garbage out perspective. And that was between, 1 to 6%, depending on the study, right? So again, still less than 10%. And again, if you're doing daily imaging, if you look at the patients who had a poor image quality, if you looked at other dates, they ended up having gradable images, right? And so I do feel like it's doable. I think there probably will be patients that won't be great candidates, people with specific, orthopedic restrictions, or certainly people who have vision worse than 2320 would probably struggle with this. Although again, the value there is not as clear in patients you don't see as well.
Okay, thank you very much, and that concludes our session.